prof, and some of them are my students or my trainees. So actually, this is nothing new to most of you, because thyroid cytology is very, very bread and butter of our daily, surveys. And the reason why we choose this topic, because it's so common, and I thought that we are going to make some kind of a tutorial so that it is very informal. You can share cases, and you can even ask questions whatever you like to ask. So actually it's not really a very advanced kind of lectures that I'm going to give. Just a basic, I would say basic, how to approach and how to report a thyroid cytology. Okay, so to make my sort of talk in order, so just a bit of overview on the usage of thyroid cytology, approach to thyroid cytology reporting, and a bit on the Bethesda system as well. So as you all know, thyroid cancer is the 9 common cases of cancer involving women in Malaysia. Yeah? This is based on statistic 2007 to 2011. In US, I think this is already the number 5th, and Singapore is number 8. So the reason why they probably can detect more cancers, I think because of their advances in their investigation tools. Yeah, and the prevalence of thyroid nodules is about 4 to 8 in Western population, but for the Asian, I think the statistic shows a bit high, like 9%, because I think we are maybe having some iron deficiency or something like that. So in Southeast Asia, it is slightly higher than the Western population. And as you all know, cancer is more common in solid cool nodules. And the prevalence of malignancy in solitary cool nodule range from 10% to 40%. I can't see my own PowerPoint here because there's people on this side of my screen. So maybe something wrong with this, I know. And FNAC has been shown to be very safe and most accurate in diagnostic thyroid lesion, with the sensitivity of 93.4% with an predictive, okay, thank you. With a predictive value of 93.4%, 98.6% for malignancy. I mean, it's quite good, yeah. The roles of cytology in diagnosing thyroid lesion. So let's see the indication of FNAC in thyroid lesion. Basically, we were asked to do or to evaluate whether a solitary thyroid nodule is malignant or benign. Second is you also can tell them whether this is inflammatory process or is it a neoplasia, because as you all know, inflammation, you have a lot of inflammatory cells and all the reactive changes due to inflammation. And third is for confirmation and categorization. Sometimes the clinician already know that it is malignant, but they would just want to confirm, because some of this lesion or some of these malignant cells or some of this malignant lesion do not require surgery, for example, anaplastic, they don't touch. Lymphoma maybe just by giving chemotherapy. Yeah? And fourth is to obtain material for ancillary tests. Yeah? Sometimes you need that to do molecular testing. Yeah? And this FNAC is done in sometimes indicated when the lesion is very small. Maybe the limit that we always receive is about 1 to 1.5 cm in diameter, yeah, with suspicious malignancy. So even though the roles is so very important, but you must remember there is a limitation to the cytology of thyroid, because as you all know, thyroid have a lot of overlapping cytological pattern between neoplastic and non-neoplastic. Being a neuroendocrine tumor, even in histology also you have difficulties in making the diagnosis of neoplasia, hyperplasia, and and adenoma. So there is a lot of overlapping features, yeah, and at the same time, even between neoplasia also there are a lot of overlapping features. Example, follicular lesion and papillary lesion, there are also various features that is overlap between the two, like follicular adenoma with follicular papillary variants of follicular variants of papillary carcinoma. You know, it shares a bit like features of follicular lesion itself. And sometimes you also have this overlap or coexistence of non-neoplastic with neoplastic process. And even in Kota Baru, I can share that 20% of our multinodular goiter, when they did a surgical resection, they found something else, you know, about 20%. This is what my surgeon has told me, but there's no paper on that. So they are coexisting, and they're like having sometimes you have two different lesion, yeah, or malignant lesion. So like any FNA for thyroid also, we have to prepare, and what are the things that we do during FNA clinic is to do direct smears. I prefer both air dried and alcohol fix because that's complement one another. Some people can even diagnose just on the air dried using MGG, and there is limitation also with MGG because sometimes the variation of the staining, you know, can be quite dense or can be quite dark. So depending on how they prepare the reagent, because it's day-to-day kind of thing. So there are certain days it's very dark that you may not be able to see the nuclear clearing and so on. So I prefer both together. And if you get a fluid samples, like example, you have a cystic specimen, I think you don't waste your specimen doing smears, but rather put it in the container and proceed for cytospin or cytocentrifuge, yeah, to condense all whatever cells inside the fluids. And I'm sure that the medical lab technology will know how to prepare this, yeah. And if you have enough material or more than enough, for example, like normally we do about 4 slides, 2 for MGG and 2 for Papa-Nicolau. So the rest we'll put a cell block. And sometimes the cell block you can also process from a blood clot, meaning that if you aspirate blood, pure blood, for example, you don't waste on smear, or you may do smears, and if you see it's cellular, you proceed straight to the clot, making it into a clot, and from clot prepare it like other histology biopsy specimen. And people also tried on liquid-based preparation, and it's you see that some of these images that I'm going to put up are actually on the liquid-based preparation, and it is very nice and clear. It's just that the cells are becoming slightly small. And core biopsy, normally what we were involved is mainly to determine whether they are getting the tumor. So we do imprint, or we do like a thyroid roll, or you just do imprint, yeah, to assess whether the biopsy is on the right tissue. So when I reported thyroid specimen, normally first thing I will search is probably to look at the cells, you know, whether there's any follicular cells or not. And of course, when you see the cells, you see what's the arrangement like, nuclear features, cytoplasmic features, and knowing that thyroid have colloids, so look for colloids. And I will tell you probably how to differentiate a bit on how colloids look like in cytology. Background features is very important to help you, like inflammatory cells, degenerative changes, necrosis, cholesterol cleft, and other components. Eh? And first thing when you see that, you already have something in your mind, you know, and when the moment you see more colloid, more inflammation, then you know that you are dealing with a benign lesion. And the more cellular the specimen or smears, you be probably dealing with a neoplastic lesion. So I normally straight away put it into 3 categories: benign, borderline, or malignant. You know, like when I say cellularity, less cellular is already like towards more colloid towards benign, and more cellular towards malignant. So you already sort of try to categorize your approach, yeah. And for thyroid cytology, I think it's not difficult because there's not many cellular component involved. Yeah? Cellular follicular cells is quite uniform, small and orderly range. Yeah? They look like honeycomb, like in your endocervical epithelium. And sometimes they can be in singles form, but not very often. They normally have sparse single cells. And yes, cytoplasm is very fragile. So you see that most of the time, what you see is a naked nuclei because the cytoplasm is stripped off. So bare nuclei is actually, if you look at them, they are just like lymphocyte. Yeah? In fact, the lymphocyte is slightly smaller, but they look like lymphocyte. They have granular chromatin, and sometimes you get a bit of folded nuclear membrane and very scanty cytoplasm. But normally in a lymphocyte, you are able to recognize a rim of cytoplasm as compared to follicular cells is totally naked. So that's how I differentiate lymphocyte and follicular cells. And lymphocyte, the size and the pattern is almost the same. So anything that is bigger than lymphocyte, for example, when you see thyroid follicles that is bigger in the nucleus, then you start to worry, or you start to take note to look for other features. And sometimes you have mixture of micro and macro follicular structures. The micro component is normally very little, and you may be able to see intact follicles in the three-dimensional form, but sometimes it's broken and you can see it's a flat sheet monolayered. Okay, but sometimes it's an incomplete follicles that you can see just part of it, so it may not be big, you know, the groups may be small. And of course, presence of colloid. And colloid basically got two forms. One is watery colloid. Normally in liquid it appears like bluish or greenish like that. And when you get a watery colloid, this is the things that people, I also sometimes mix up with serum. Yeah. So normally that's why if you do the aspirate yourself, you know whether your specimen is bloody or not. So if in a bloody situation, you can anticipate a lot of serum then. So in the smears, if you see a lot of clots, for example, here and there, so areas around the clot, you know, like when you do centrifugation, the serum will be just next to the clot. So be careful that not to interpret that as a thin colloid. And deep dense colloid or thick colloid is relatively easy because normally it's cracked. It breaks and it cracks. So it's just like a gum. You put a gum or either chewing gums or they call it bubble gum or whatever. So it's like looks very thick, like in this pictures, yeah? And you can see that it's cracked. So that's how this dense or the thick colloid look like. So for the cytology, this is a variation that you may see in in the follicular cells, sometimes in a group, and sometimes you can see microfollicles, and sometimes it's folded. When it's folded, it looks as though it's overlapping, yeah. But normally it's just like one or two cells because it's just folded. So it's just like one monolayer with another monolayer comes together. So normally it's like 2 cells thick. But the moment you see more than 2 cells or like nucleus come to more than 2 or 3 like that, I think it's already like severe overlapping. And in this cytology workshop, they consider that as an architectural abnormality already lah. And to help us in making that diagnosis, I think we cannot ignore these background features. Background features is very important because it will tell you that degenerative changes occurs when the lesion is of a longer duration. For example, martinolar goiter, iron deficiency. So you get all these degenerative changes. So the clue for that is you see a hemorrhagic smears, cystic degeneration, and you see a lot of foamy macrophages, cholesterol cleft like that. Yeah. So this help you to say that this is a benign lesion. So with this Bethesda system reporting, I think most of you all are very familiar that it is established in US, Maryland, US, Bethesda, just like our cytology for cervical cancer, cervical reporting. So basically it's divided into three categories. This is just like how we report our non-gynae specimen, isn't it? Unsatisfactory, non-diagnostic unsatisfactory, benign, atypia, follicular neoplasia or suspicious of follicular lesion, yeah? And suspicious for malignancy and malignant. So as I go along, probably I just highlight few cytological features on some of these examples, not all. I think it's too long. All right. So as I mentioned, Bethesda system was established in 2009, but it was reviewed or updated in 2017, starting in 2016, I think, in Japan, Oklahoma. So when they review, I think nothing much have changed over the category part. It's just that they found that the risk of malignancy have changed a lot, because when they got the data of for risk ROM is a risk of malignancy. When they got the data of 2010, I think that time NIFT was introduced. NIFT is a new entity where you get a non-invasive follicular tumor with nuclear features of papillary, papillary carcinoma. So, but it is benign basically. So before it is included as a benign, it was considered as a cancer. So you see that the risk of cancer was higher in the category of atypia, category 3, for example, follicular neoplasia, suspicious malignancy, and malignant. But since they identified it as benign, not cancer, so the risk of malignancy becoming lower or less in these three categories. But for the benign, it is not affected at all. You can see that it's still 0 to 3. The rest slightly decrease, because they already sort of categorize it. But for cytology, I think we don't have to worry about the NIFT because it is a diagnosis on histo. So cytology, you are allowed to choose, either these categories or follicular neoplasia, suspicious for malignancy. I probably highlight it later, on the NIFT. And very important that Bethesda also put up a suggestion, for the clinician or for the in terms of their management. So you can see that every category, except for I think for 5 and 6, lobectomy and thyroidectomy, others is just follow up and even you do a molecular, to differentiate between benign and malignant. So first category, before we can say the specimen is adequate or not, or satisfactory or not, then there is a criteria that people generally use, is the presence of 6 group of benign follicular cells, and each component or each group composed of at least 10 cells. But this numerical criteria, I think, is not really. You cannot be very strict on it, because there are also some exception to that. Like if in colloid goiter, for example, where you see just colloid and ultrasound shows is colloid, is a cystic colloid goiter. So it is, even though there's not enough follicular cells, you consider as benign or category 2, And specific diagnosis that you can make, even though there's not much of follicular cells of 6 group, for example, you see a lot of lymphocytic cells or lymphocyte of mixed population. This is thyroiditis. So you can make a diagnosis on that, even though the specimen has not got 6 groups. And similarly, if you have a few groups, but the groups already show you a significant or a definitive diagnostic material. So like even though You can also call whatever you want to call, malignant or not, but maybe just a comment on the limitation of it. But I think it can be, it is not under unsatisfactory. It is becoming satisfactory, and you are able to report. And but sometimes in our setup, sometimes because sonography is not done by us, you know, and it's done by the ultrasound the radiologist, and sometimes they write in the ultrasound of you know, high Thyroid 3, Thyroid 4, which is like neoplasia, for example. But they give you cyst, or they give you something that, you know, colloid, that it is look like benign. Even that also, you can make a diagnosis of benign, but I will still put a comment that it may not be representative, you know, because even though it is an exception that you make a diagnosis, but the ultrasound findings doesn't support, so we have to sort of warn them that it may not be representative. So I think the common cause of non-diagnostic normally due to operator or techniques. Yeah, sometimes you aspirate too much blood. You allow, because we do, some people allow suction. Yeah, so much of pressure sucking the blood. So it is like too thick in blood on the slide. So you see that sometimes you got the cells, but then it is trapped in the clot. And I think once it's trapped in the clot, very difficult for you to really look at the nuclear features. And even though there are a lot of cells, but this is the limitation that I think you have to be, you have to really know your limit. Yeah, and sometimes it's poor spreading, because spread depending on the pressure of you know, a slide that you spread, it sometimes smash the cells or crush the cells. And that also make it difficult for you to appreciate the normal architecture or the normal cytological features. Yeah, and of course, a drying artifact is another thing. You know, if you delay in fixation, then everything bloated up and it become bigger and very pale and blur. Yeah. So example, you know, sometimes you get a big chunk of tissue, but it is turned out to be your muscles or skeletal muscles near the neck, and this is a lot of colloid and follicular cells just here. And sometimes you just get cystic changes. This is the thin prep kind of specimen. You can see that it's very beautiful and clean, and the cell is slightly smaller. So this is the thin prep, and this is a smears that have a dry artifact. And sometimes you see this, yeah, a lot of necrotic debris, something like necrotic, but I think this is like calcification or cyst content that becomes sort of solidified. So you think you are seeing something, you know, oh, there are a lot of things, but actually there's no cells there, and it's still under category of non-diagnostic or unsatisfactory. So normally we ask them to repeat, if indicated, and preferably under ultrasound guide. Okay, so second category is a benign lesion. Benign lesion contribute to most of our daily work. I think it's about 60 to 65%, or even some centers got it about 80% of their workload actually based, from benign lesion of the thyroid. And these categories will include hyperplasia, adenomatoid nodule, colloid nodule, thyroiditis, and Graves' disease. And as I mentioned, in 2017, when they reviewed the Bethesda system, nothing have changed within this category. So adenomatoid nodule is very simple. You see a lot of colloid, a lot of macrophages with pigment-laden hemosiderin basically, and sometimes foamy cells. And you look at the follicle, which is very small and discrete nuclear membrane, and hardly any cytoplasm sometimes. And sometimes you are able to see these quite large follicles, which is rather monolayered, and small broken follicles here, and microfollicular structures. So there are a lot of variation, some sparse to moderate cellularity, because depending if you have a colloid goiter, then it is basically colloid, not much of follicular cells. And of course you can see thin and thick colloid, and molar layered sheets and honeycomb pattern of follicular cells, sometimes in three-dimensional ball, and rarely you see microfollicles. And the moment you start to see a lot of microfollicles, think of a higher grade of lesion or suspicious, yeah. And normally, as I mentioned, cells have scanty to moderate amount of delicate cytoplasm, and you may be able to see anissionucleosis. Anissionucleosis means variation in nuclear size, yeah, size. So depending on the activity of the thyroid, it is if it is hyperthyroid or active thyroid, you see a lot more of anissionucleosis, meaning that small and big nucleus. Minimal overlapping, as I mentioned, should not see much, yeah, in a normal, because one or two cells should be okay, 2-3 cells I would say, but the more you see nuclear stacking on one another, then you have to think of small severe lesion, yeah. And you may be able to see granules, and sometimes you also get to see Hurtle cells, but not much, yeah, in a benign condition. And of course you see macrophages, as I mentioned just now, yeah, to indicate a cyst change, and sometimes the cells may be a bit reactive in case of for reparative change, yeah. So this is colloid. Sorry. I don't know how it goes into that very fast transition of my slide. But anyway, you can see all this colloid basically cracking like of another film, another layer. Never mind. So sometimes you're able to see oncocyte. Oncocyte is to me a bit difficult, you know. Sometimes it imposes you a lot of anxiety for me, because the more I say oncocyte, because so many other lesions have oncocyte, yeah. So oncocyte is basically an abundant, dense, finely granular cytoplasm. They look a bit like squamous sometimes, and large nuclei with prominent nucleoli. They have prominent nucleoli, and they have binucleation and multinucleation. And you commonly see this in Hashimoto thyroiditis, and sometimes even goiters, and of course in neoplasia like follicular lesion, and even papillary lesion. So because it is like a mimicker, so when I see you know, there are also other lesion or other organs that give rise to this follicular or oncocytic cells, like your breast, salivary gland. So being salivary gland is so near to the thyroid, sometimes we make mistake, you know. I remember having one FNAC on the thyroid, yeah, lateral probably, but why I see so many inclusion, but the cells, you know, look oncocytic, and wondering, is it thyroid, is it something else? And biopsy turned out to be a pleomorphic adenoma of the salivary gland. So because salivary gland also have oncocyte, and you can even see inclusion sometime in oncocyte. So that is really a pitfall for me lah when I see oncocyte. And cyst lining is another thing that because it is a metaplastic, like, you know, it's a lining of the cyst that some literature mentioned that it is actually having a thyroglobulin antigen, means that it is a thyroid derived, but sometimes they also show that it contains markers for macrophages, so like in between thyroid follicles and macrophages. So they also have shared this entity of like the nucleus can have inclusion sometimes, grooving, you know, that really you worries lah, you make you worries, you know, when you see this a lot of cyst lining, yeah. Okay, so clinically or histologically, it is quite easy to diagnose adenoma and goiter. And as you all know, most of the time adenoma is single nodule, and it has complete capsule, yeah. adenoma and goiter is you don't really see intact capsules or complete capsules. And in adenoma, the follicles tend to be very uniform. But there is such thing as macro follicular adenoma. Macro meaning it's big. That is really difficult sometimes. But whereas in goiter, it is like a variation in size of follicles. Even in histology, I think you can appreciate that better. And in goiter, you see a lot of degenerative changes. So a lot of cystic dilatation, and a lot of macrophages, even in histo. And of course, both do not have any invasion, in the capsules. So the second common thing that you see apart from colloid goiter is Graves' disease. Graves' disease, I think, is easy because it is a hyperfunction kind of follicular cells. So you see abundant cytoplasm with flare-like or flare cells, they call it, with a protrusion or flaring of the cytoplasm like a fire flare kind of thing, fire. So, and these Graves or hyperfunction thyroid nodules may have variation in nuclear sizes that you sometimes worries, and this is basically marked anisio-nucleosis. And in a treated condition, there's another problem, because sometimes when patient was given carbimazole, that will create another nuclear atypia, because of the drug. So that will also make your cell become abnormal or atypical. That sometimes everything look like Graves, like type 2. Suddenly you see these atypical cells, then you put it under type 3. So Hashimoto is common next to Graves' disease or hypoplastic nodule. And it is an autoimmune disease, normally occurs in women around 40 to 50 years old. It can be coexist with other autoimmune diseases like rheumatoid arthritis, Sjogren's syndrome, pernicious anemia, and so on. But it can still be part of the early like lymphoproliferative disorder sometimes, because long-standing Hashimoto thyroiditis may evolve to lymphoma. So cytologically, it's quite straightforward. You can see a lot of lymphoid cells. And the most important thing is that this lymphoid cell is heterogeneous. Sometimes you can even see the follicular cells, germinal center cells. I mean germinal center cells, meaning that you can see tingible macrophages, immunoblasts with dendritic cells. So that is very important, and at the same time you also see Hurter cells of monolayered sheets. So that is Hashimoto thyroiditis. But the moment the lymphoid become like monotonous or very atypical, then that will be slightly atypical, and you have to put it under category 3, type 3. So depending, and even the Hurter cells can be quite abnormal as well, and you see if it's very clear inclusion, grooving, and things like that, you can also put up into category 3, because you can also get papillary CA in the Hurter cells, in the Hurter cell variant. Okay. So next is category 3, which is atypical of uncertain significant AUS, or follicular, another terminology that you can use, follicular lesion of undetermined significant FLAS. So it is recommended that you stick to one, either you use AUS or follicular FLAS, to just minimize the confusion to the clinician. So my centers been commonly use FLAS and during the revision of Bethesda in 2017, they recommend that the descriptive language or descriptive words for atypia must be specified, whether this is cytological atypia or architectural atypia. So what you mean by architectural atypia is when you see crowded clusters, as I mentioned, more than 2-3 thickness of cells or nucleus, and whether they are in microfollicular sheets, papillary clusters, yeah, isolated cells, things like that. So that is like architectural features. Yeah? And cytolytical features indicate whether the cytoplasm, how is the cytoplasm, thick, thin, absent, chromatin pattern, yeah, whether it's coarse, pepper and salt appearance, yeah, and nuclear membrane, whether it's smooth, irregular, grooving, pseudo inclusions. Yeah? So that's the nuclear features. So cytological features. So sometimes you have both changes in both cytological and architectural. So, but we know that cytological features atypia is more significant in predictive malignancy than the architectural features. This is, I think many studies have shown that the nucleus features is the most important one, yeah. But don't forget about the architectural features. So basically, when you say FLAS or AUS, is that the architecture or the nuclear atypia is more pronounced than the one in benign lesion, but not sufficient to characterize as suspicious or malignancy, yeah, or suggestive of. So it's like a diagnosis in between benign and malignant or neoplasia. So that's why I mentioned that atypia is something that you don't see colloid, you don't see inflammatory cells, you only start seeing cells alone, yeah. Then you are already on the higher grade, yeah, like FLAS or AUS. So, but you just cannot dump it into that, you know, or abuse it. So that's why they try to control it. Like most centers should not exceed 7 or 10% of your reporting. So if you've seen 10 thyroid cases in a day or in a week, you should not exceed, you know, like one case of FLAS or specimen which is diagnosed as FLAS. But in my setup, I think sometimes I see more because we don't have ultrasound before FNAC. So you don't know what's going on, you don't know what's the ultrasound finding, you know. So you need them to do ultrasound. So how to do it? Sometimes you just put a FLAS so that you can get the ultrasound finding or be repeated but under ultrasound. So because that's a management of FLAS. Normally is that you repeat under ultrasound finding or you do it molecular study as well. So maybe we in Malaysia, because of the radiological ultrasound facilities is not as good, so we end up maybe having FLAS a bit more than the rest, yeah. Okay, and Hurter cells is actually another entity. When you get FLAS, you also need to identify whether this is a purely or this is a Hurter cells in origin. Yeah, normally again it is not very cellular, but it's composed exclusively. Not many cells, but it's all pure Hurter. So even though it's not many cells, but you're worried. You know, when it is all pure Hurters, no inflammation, no colloid, you may be dealing with a follicular lesion, yeah. So or Hurter cells adenoma. So that's the reason why you have to specify Hurter cell AUS or Hurter cells plus, whatever. So I think this is another thing that you also end up by calling AUS or FLAS is that artifact. You know, sometimes air dry artifact, clotting artifact. You know that it's so cellular, but it's all trapped in the clot, and you are very worried. So at the end of the day, everything look like a three-dimensional shape or architecture abnormality. So you end up having to call it on the higher lesion so that you can get a faster repeat or sometimes an ultrasound guidance. Yeah. So, but the criteria is still there. You need to see a background of architecture abnormality or with or without a cytological abnormality. So example that you see architecture abnormality, this side you can see is nice papillary. So this is cannot be FLAS because it's already like fibrovascular core papillary structures. But in this case, I can't see any papillary structures. I can't see the core, fibrovascular core, but it is all folded like that. You'll be very cellular. So maybe not benign or maybe benign, you know, looking at the other cells. No, so this is like very, very thick and folded and maybe three-dimensional kind of thing. So that you are worried. And this is the microfollicular structures. You can see some are monolayered like this, but in some areas it look like microfollicles. Yeah. So this is considered as flask. And when you say nuclear overlapping, as I mentioned just now, how overlap it is, you know? So is it 1 or 2 cells, 3 cells, 4 cells overlap? So we can consider this area is quite overlapping, yeah? Because it's so dark, maybe more 2 to 3 cells, I don't know, maybe three cells. So this is like a mild overlap, but here it looks like monolayered still with 2 overlap. But here is quite thick, yeah? And this is microfollicular structures. So cytologic atypia, as I mentioned, you see it like this is benign as comparison.